Tell us how you recognize and manage nephritis associated with immune checkpoint inhibitors. Renal events are uncommon, with rates perhaps as high as 4% only reported in one studies. There have been 3 forms described in the literature. These include acute interstitial nephritis, minimal disease, and immune complex glomerular nephritis. All 3 will manifest as acute kidney injury, or AKI, and this is noted with a rise in serum creatinine. In early stages or early grades of the toxicity, most patients are asymptomatic. However, they can progress rapidly if left unmanaged. The early symptoms include fatigue and weakness. The time to onset is about 6 to 12 weeks, but there have been some reported cases that have occurred as late as 8 months after therapy. Some of the different patterns that may be noted are acute tubular nephritis, lupus-like nephritis, granulomatous nephritis, and immune complex glomerulonephritis. Some of the vague early symptoms may be signs of dehydration, proteinuria, edema, an elevated serum creatinine level, eosinophilia, decreased urine output, and with more advanced cases, patients may demonstrate hypovolemia and pruritus. Evaluation includes many different stages. The first thing is to evaluate for other causes, such as pre-renal causes of acute renal injury and post-renal causes. This may include medications that are metabolized by the kidney that may lead to kidney dysfunction. And one of the biggest culprits is NSAIDs. So it's important to do a full medication reconciliation with patients. Explore whether or not a patient has just had IV contrast dye and whether or not they had a subnormal kidney function to start, because they may be having difficulty excreting that IV contrast dye. Assess for hypovolemia. So were they fluid deficient initially, and they just may need some fluid resuscitation to reverse that acute renal injury. Urinary tract infections can lead to AKI as well. You also want to consider additional post-renal obstruction as potential causes. Evaluation then is going to include obtaining a urine, protein, and creatinine ratio. It's important to follow the creatinine and protein every 3 to 4 days once AKI has been identified. Assessment of electrolytes and acid-base balance is also important, as these may be dysfunctional or abnormal as well with acute renal injury. This can be a very serious and life-threatening complication if left unidentified, specifically when patients reach a creatinine level of 3 times their baseline. And I just want to stress that it's important to understand and have an assessment of the patient's baseline creatinine. We had a reported case where a patient presented to our clinic with a creatinine of 1.8. Now that might not sound very significant to you. However, their baseline serum creatinine initially was 0.7. So that was a significant increase for this patient and warranted further evaluation with nephrology to help us identify the cause. And indeed, for that particular patient, it was thought that it was due to immune checkpoint therapy. So comparison to baseline of all your labs is very important. Some of the risks of leaving this unresolved or undiagnosed are that the patients can have complete renal failure and in very, very rare cases may require permanent dialysis. Some risks that may contribute, in addition to the other medications that I talked about, that may increase risk of acute renal injury are proton pump inhibitor use, which has been cited in leading patients to acute renal failure, and also several antibiotics. So again, that full medication reconciliation is important. Management may be as simple as limiting or discontinue nephrotic medications, or adjusting doses to a patient's creatinine clearance. Fluid resuscitation will be important. Nephrology consult in more severe cases may be recommended, as they may require a renal biopsy for full diagnosis. And as I said earlier, occasionally, on very, very rare instances, a patient may require dialysis. As with other toxicities, corticosteroid administration at 1 to 2 milligrams per kilogram per day in more severe cases. That would be a grade 2 or higher of nephritis. And again, that will be titrated over the course of a month to resolution.